I'd like to now introduce our next speaker who will be discussing their collaborative contraceptive initiative and policies around using the Medicaid CMO perspective. I'd like to welcome Dr. Alan Joffe. Dr. Joffe is a graduate of the University of Maryland School of Medicine and has over 35 years experience practicing OBGYN in Atlanta, Georgia. He received his Bachelor of Arts degree from biology in Adelphi University and is a board-certified physician by the American Board of Obstetrics and Gynecology. Dr. Joffe is currently in private practice as an OBGYN in Atlanta, Georgia, and is a member of multiple medical associations and societies, including the Medical Association of Georgia, the Georgia OBGYN Society, the Southern Medical Association, and the American Fertility Society. Dr. Joffe currently serves as a medical director on the executive committee of OBNet, Women's Healthcare Network. He has previously served as the chairman of the OBGYN department at Northside Hospital and was part of the Northside Hospital Medical Executive Committee. I now would like to welcome Dr. Joffe. Dr. Joffe, to you.
Yes, good afternoon. I hope everybody's having a nice day. We're going to talk today about a collaborative contraceptive policy from the Medicaid CMO perspective. And I'm going to start advancing the slides to discuss what we have done here in the state of Georgia. I am a community medical director at the Peach State Health Plan. We are a CMO. In the state of Georgia, the Medicaid patients, approximately 2 million folks, are divided amongst 3 health maintenance organizations, which are called CMOs, and a fee-for-service Medicaid. We have about 70% of the Medicaid lives. Concept here was to try to introduce LARC, immediate postpartum insertion. I'm sure everyone on the call understands that LARC is long-acting reversible contraception. And the ones that we have discussed in the past, obviously, are the 2 types of IUDs and the implant. The new concept here for physicians is the idea of placing an IUD inside the uterus within 10 minutes from delivery. For physicians of all ages, but specifically those in their later parts of practice, after being out for 10, 15, 20 years, this is a counterintuitive concept. To place an IUD, which is very small, as compared to a large cavity of a postpartum uterus, just didn't seem to make a lot of sense. Even though the concept has been out there a while, everybody assuming that the expulsion rates would be dramatic and therefore the idea would work. Well, in fact, that's not the case. So the collaborative approach here was to include the Georgia OBGYN Society, which I am also a member, and the Medicaid Department of Community Health and the Department of Public Health, all working together at various points along the way to establish a policy, create a payment system, remove as many barriers as possible, set up a training program for the physicians and residents in the state of Georgia, and then get this process underway. That is no small task. In slide 1 that you can see here, we were able to create a policy with the Department of Community Health, DCH as we call it. We presented a program and a PowerPoint to the Department of Community Health and subsequently to the Department of Public Health, which sees our patients first, as that's where they get their positive pregnancy tests. From the Georgia OBGYN Society, which had a subject matter expert, Missy Kotke, that you've heard from in the past. Missy put together a PowerPoint presentation, but unfortunately in presenting this concept to many major institutions, which heard her presentation but did not feel that this was grant-worthy, I attended the Georgia OBGYN Society, heard this conversation and presentation, and thought, this is a really good idea. I like to describe this as my V8 moment, listening to this and hitting my forehead and saying, oh my goodness, why have we not been doing this? As this would be applicable not just for the teenage patient receiving her health care through the Medicaid services, but for all women, whether they be getting their care private or public. And I then approached Missy and I discussed this with the senior leadership within Peach State Health Plan. Now, all CMOs have access to a granting process. And for reasonable and quality programs, grants are considered. I championed this grant to my senior leadership, suggesting that LARC was really a great idea, and got that grant. And with that grant money, we were then able to proceed with creating a PowerPoint and proceed beyond that with developing a pelvic model. That pelvic model is something that we felt was essential for teaching the residents and private staff. Now, if you look at the next slide, the state of Georgia is divided into 6 regions. They're called perinatal regions. Each region has a medical center that's a tertiary center with a residency program. This was established many, many years ago to try to organize the delivery of health care so that there be a tertiary center well located and ready to take care of high-risk moms and low birth weight babies. We used this as the approach for training. We felt that we could take this training PowerPoint and the model that we created with us to each one of these centers and invite 2 different groups of physicians, the residency program directors, their fellow physicians teaching the residents and the residents for one session, and the private practitioners practicing at the hospitals either there or the ones nearby, and present them the same PowerPoint. And with that, what we did was then go to Albany, Columbus, Macon, Savannah, and the Atlanta metro area, and the last one will be Augusta next week. 6 major presentations, and then we chose sites in the local areas where there was a high number of Medicaid deliveries. Those Medicaid deliveries were pretty much centralized in specific hospitals. We then presented the exact same process to those staffs. In almost each case, they were all private staffs, going through the PowerPoint and allowing each doctor on the staff to practice on the training model and use the various methods for introducing an IUD to postpartum uterus. Now, on the next slide, you'll see these key components. Number 1, the Medicaid policy. When you're starting with a new concept, a policy is required by the Department of Community Health for their support. So we wrote a policy using the combined talents of our subject matter expert, the people within Medicaid, and of course the Peach State Health Plan. We convinced them with our presentation that this policy would be good for our state, addressing the unfortunately high number of teen pregnancies in our state, repeat teen pregnancies in our state, and the birthing intervals that's a problem, as there's a high number of births within less 2 years from the previous delivery, and the low birth weight babies. All of these were projects that the Department of Community Health is interested in having other approaches, and unfortunately not very successful. So we explained to them, we got this process approved, a policy was written, and then the key here is opening up codes within the Medicaid reimbursement system. Because if you think the process through, number 1, is it a good process? Number two, do we have a Medicaid approved policy? Once that's approved and we decide to roll out the training program, physicians will want to begin to do this, but are they going to be reimbursed? Pharmacy directors at the hospitals need to know what codes, how much the Medicaid will be paying for the various devices. Will they pay for them on a new site, since to date they were only placed in outpatient situations? Now they're going to be in the hospital. Where do the IUDs go? They go in the Pyxis. Who puts it in the Pyxis? How are they retrieved? Are they placed on the back table of delivery? The nursing staffs needed to be involved to cooperate in placing and setting up the IUD insertions. We needed to establish an informed consent. When would the informed consent be used? Of course, the informed consent is best done in the third trimester of pregnancy, because it is very difficult to have these conversations while patients are in labor. And the bottom line, though, is nothing is going to happen if it's not reimbursed. So we in the CMO use the talents of the people inside our CMO who deal with these issues, deal with billing, deal with billing and reimbursement. And as you'll see on the next slide, here are the reimbursement rates. Here are the current reimbursement rates, and if these are J codes, obviously, these apply to the hospital. And as you can see here, these are the codes that are being paid here in the state of Georgia for the IUDs, one with or without releasing hormones. That's the Skyla, Mirena, and of course the Paragar is also involved here, and the Nexplanon. And if you turn to the next one, you'll see the reiteration of the basic CPT codes. And as we go from slide to slide, you'll see the V codes. Then you'll see the CPT procedures, the J code for the implants, the already well-known IUD coding. These IUD codes are presently being used as outpatient interval procedures. And finally, the V codes. Once we established the reimbursement process, we then carried the PowerPoint, which was approved, the model, which was approved, and did a first test run down in Albany at their perinatal center. It was fascinating because the questions that we thought we would get weren't the ones that were asked. And it was most interesting, the concept about placing an IUD in the first 10 minutes brought out some very interesting questions. What happens if it was at 11 minutes or 15 minutes? Well, there's obviously an answer to that question. Of course you can place it then, but people were taking the recommendations very literally. A question about what happens with expulsion. Is there going to be a reimbursement for the IUD that needs to be replaced? And eventually we were able to fine-tune the presentation so that we included in our PowerPoint those important features. PowerPoint discusses how to place an IUD, for example, manually, how to place an IUD with a long ring forceps. Then we had both of those things available for the doctors to practice after the presentation. The PowerPoint would include things like the codes that I just showed you, so that the pharmacy directors at these meetings, the administrators who are organizing the nurses, the head nurses in labor and delivery, could all see the codes, know how to code them, and get this presented. So ultimately, it all rolled out first as a policy, then as a reimbursement structure, then as a training program, and after we went through our first dry run, we then went from location to location to the 6 perinatal centers and to the other hospitals that were large Medicaid users. Once we got to that point where we have everything we believe organized and all those barriers removed, the last phase will be to create an educational pamphlet and program And this program will be then rolled out to the patients. Now, this is when the Department of Public Health comes in. The Department of Public Health cooperating with us, and that is extremely important because the Department of Public Health gets these patients going forward. They're the very first ones that sees these patients. They are, in fact, doing the first positive pregnancy test. So the Department of Public Health came to us and said, well, we want to establish pilot clinics and a pilot program. This pilot clinic and this pilot program needed locations because there's clinics all over the state. So we were able to go internal into our statisticians and locate by address and geographic location where the highest concentrations of low birth weight babies were. And that has then been translated into locations for the pilot programs for the Department of Public Health. We'll create the educational piece, and when the patients come to register for pregnancy, they will get a educational, whether it be a pamphlet or a long paper, an opportunity to discuss this with the registering nurse who's taken their original history, and then that same information will be given through the OBGYN Society to all the physicians, so they get education at the front end, and then they get education at the back end of the labor, so that by the time we get to labor and delivery, the informed consent is done, the doctors are comfortable, the patients are comfortable, the nursing staff is comfortable, the administrators are comfortable, the IUDs are available, and then the entire process should wrap up. So that is what we've done here at the state of Georgia in Medicaid to get the immediate postpartum LARC process underway. Are there any questions?
Thank you so much, Dr. Joffe, for your presentation. While we wait for participants to chat in the questions, we have a few that have come in already. Dr. Joffe, you mentioned patient pamphlets just just before. How is Georgia planning on informing patient populations beyond pamphlets? What are some of the processes that you're thinking of doing to roll out and make this more well known?
This is still in the discussion phase. I don't want anyone to think that we have every I dotted and every T crossed. We have several points of entry for our patients. We're not going to advertise, I don't believe, in general publications right now or billboards or the like. We're going to start first with direct one-on-one contact. We've found throughout the years that patients talking to patients, nurses talking to patients, and physicians talking to patients is the best way to disseminate the information. There are also, our CMO has a Healthy Start program in which we interface with the patients for a whole host of educational opportunities in pregnancy having to do with nutrition and breastfeeding, and we will include this educational piece within our own Healthy Start program, which we do with every single patient. Once we get a notification of pregnancy, that process begins with our medical management department. Our expectation is the other CMOs will follow in line with that as well.
Great. Our next question has to do with the pelvic models that you described previously, and I know that Dr. Kotke on a previous call had also described them. Can you describe how they help providers and maybe where you got them from and how you were able to pay for them and that training?
Sure. Well, first of all, the cost for these have been taken care of by my plan. I'm very proud of my senior leadership that stood up when nobody else would do so and grant the necessary funding for this process. Being a private practitioner, I haven't had the opportunity in the past to deal with these costs, the simple cost of PowerPoints, the cost of creating folders, slide decks, and so forth. So it's been a learning process for me as well. And what we did was we researched with regard to the model what was available countrywide. It was really remarkable. We had one model producing company that would have been real nice and do one for us for $40,000, really. Eventually we were able to find excellent reproduction of the postpartum pelvis made in an ingenious, simple, and inexpensive way. In a previous slide, this was referenced in Dr. Kotke's PowerPoints. It's out of Stanford. We followed, for the most part, the recommendations in that YouTube video and recreated the whole thing. Costs about $800 from start to finish. Now, the reason why this is very cool is that the way the model is set up, the vulva looks and feels very similar to an immediate postpartum vulva. And the cervix that is simulated actually feels in size and shape like the postpartum cervix. And then the cavity is as deep as a typical uterus is right after delivery. And the abdomen piece is relaxed just like it feels after a baby is born. So what our doctors are noticing when they're practicing on these models is this feels just the same as when they go after a placenta. We typically have to do that if a patient is bleeding postpartum and the placenta is not spontaneously separating. We're used to going up and reaching up inside the uterus to separate the placenta manually to contract the uterus and decrease the bleeding. Same sensation is felt when you use this pelvic model. So they're easily able to place the IUD and their fingers go up through this simulated vagina and cervix and into the uterus, and it seems to work very, very nicely.
To follow up on that, how have the trainings in hospitals been going, and how is uptake proceeding?
Well, I didn't hear the whole question. I heard how's the training going. The training is going remarkably well. What was the second part of the question? I'm sorry.
How is uptake from the training, and how have residency programs and other programs been responding to this training?
Well, it's been remarkable. I expected one or two people to be shy, not be shy, and come up and try this. That has not been the case. Every resident in the residency programs we've been to have immediately come up to do the insertions and try many, many times. When we found that this was so popular, I really was able to immediately commission, through the generosity of the Peach State Health Plan, a second model. And incidentally, I have a request in, and I expect it to be approved. We're actually going to create these models for each one of the 6 residency programs and then gift them to each program, because at each location the residency director said, great, this is terrific. We'd love to have one of these for our residents to practice on, and not just for this year, but for years going forward. These models appear to be very durable, and for whatever is not durable is easily replaceable. So we think that's going to be terrific. And as far as the uptake is concerned, we're not going to know about the use of the IUDs for, I'm guessing, 2 to 3 months down the line, when they go through the process at each one of these institutions to introduce the concept by the IUDs, set up their protocols, talk to the patients in the clinics before they start rolling out the IUD and placing the IUDs.
Has there been any evaluation of these trainings, or if there hasn't, are you planning to evaluate the training? And I'm assuming not yet, but have you seen any increased LARC placements immediately postpartum due to the trainings?
Well, yes and yes. The Georgia OB/GYN Society, which is our partner, and I would be remiss if I didn't say that they were instrumental in establishing the places in each one of these perinatal centers to give these lectures, finding the auditoriums, using the knowledge they had for other presentations, for other concepts. For example, we had a year's worth of training going around the state for shoulder dystocia with a sim lab for that as well. So to answer that question, this is a collaborative process. They're going to be, and they are continuing to survey the situation And as this LARC seems to be going viral in our state, the Department of Public Health is going to be involved in taking stock and getting records of the LARCs that are being ordered and done, and the claims are coming in. And there's also a gap QC process going on that has now determined that LARC is their project as well. So we should be getting information through the gap QC as well.
That's wonderful. Our next question is wondering that you spoke mostly of IUDs. Has any of the training that you've worked on also addressed the implants?
In this particular process, when Dr. Kotke completes her presentation, and before we go, we always offer Nexplanon, as she, in fact, is a Nexplanon instructor. But in each case, no one's been interested because they all know how to do it. So we really haven't much of a request for that.
And then I guess our final question that's in our chat box is, do you have any data on the expulsion rates on postpartum LARC versus later placement from any of the work that you've done with these trainings?
No, we're not going to have data for that kind of information just yet. The data that's included in the slide deck that Dr. Kotke originally presented shows a variance between 2% and 37% expulsion rates, and those are taken from studies that are unfortunately relatively old. So I don't think that we would be able to give you that information now, but the beautiful part about this is as the usage starts to rise, we're going to be able to collect the information that you reference here. I think we'll all learn a lot going forward. There'll probably be some things that we hadn't thought of. Quality of the training, the ability to place comfortably an IUD all the way up in the back of the uterus, expulsion rates, perforation rates, and so forth. But we're not going to really have that just yet until this really ramps up.
Well, on behalf of our learning community, I would like to thank you, Dr. Joffe, for your presentation and talking to us about what Georgia's been doing, Georgia's CMOs have been doing around funding and supporting training within the state. So thank you so much. We truly appreciate your presentation.
It's been my pleasure.